The single leg hop test for distance is a performance-based outcome measure used to determine a patient's readiness to return to sports involving running, cutting, or jumping post-knee surgery. It is most often used after ACL reconstruction. This test reflects the patient's confidence in the limb, their force-generating capacity, their ability to tolerate a load, and their neuromuscular control. Primary tissues involved include the knee muscles, such as the quadriceps and hamstrings, and the knee ligaments, especially the anterior cruciate ligament. The single leg hop test is performed after knee surgery during the functional phase of rehabilitation. The patient should report pain of 0 out of 10. Their lower extremity range of motion should be full, and the strength of the quadriceps and hamstrings should be at least 80% of that of the uninvolved limb. A negative anterior drawer test, signifying an intact ACL, should be present, as well as trace or no effusion in the knee. This test would be contraindicated if completed too early in the rehabilitation process, possibly risking the integrity of the newly reconstructed ligaments. It is also contraindicated if there is notable edema, pain at rest, or a recent fracture. The psychometrics for the single leg hop test are as follows. The test-retest reliability is high, between 0.79 and 0.99. The sensitivity is 52%, and the specificity is 97%. The minimal detectable change is plus or minus 8.09%. Literature indicates that the predictive capacity of this test is good. Those who have recurrent instability on return to premorbid level of activity have lower pre-training symmetry scores than those that did not, but further research is needed. To administer the single leg hop test, have the patient stand with their toes behind a marked line. The patient should be wearing sneakers. Ask the patient to stand on their uninvolved limb and to hop as far as possible, landing on the same foot. The landing must be held for at least 2 seconds, and the patient's arms should be held either behind their back or at their hips. The test administrator should measure the distance from the line to the heel of the landing foot. 3 attempts are completed, and then repeated on the involved limb. Make sure to ask the patient how they feel during the test. Pain or feelings of instability may be an indication that the patient is not ready to return to sport. This test should be repeated throughout the rehabilitation process to record patient progress. We will now demonstrate an application of the single leg hop test. We will now be performing the single leg hop test. What I'm going to ask you to do is to stand on one leg. You can just watch me. We're going to start with your toes behind the line. You're going to stand on one leg with your hands either on your hips or behind your back, and you're going to jump forward as far as you can and hold that for 2 seconds. We're going to repeat that hop 3 times on each leg. I'm going to measure the distance that you hop. And if you have any feelings of pain or instability during any part of this, let me know, and we'll stop the test. Any questions? No. Okay, let's go ahead and start on the uninvolved side first, and whenever you're ready. Good. 102 centimeters. 101 centimeters. 103 centimeters. Let's go ahead and try the other foot. 98 centimeters. 102 centimeters. 92 centimeters. Good job. How are you feeling? Good? Great. That's a single leg hop test. A hop is considered unsuccessful with any of the following outcomes. Number 1, The contralateral lower extremity contacts the floor within 2 seconds of landing. Number 2. Either upper extremity contacts the floor within 2 seconds of landing. Number 3. An additional hop at landing is necessary to maintain balance. Full hop occurs. Remind the patient of the instructions and repeat, discarding that measurement. The distances from the 3 hops are averaged for each limb. Comparison between limbs is made by taking the distance of the hop on the involved side as a percentage of the hop on the uninvolved side. For example, if the patient hops an average of 97.3 centimeters on their involved limb and 102 centimeters on their uninvolved limb, such as our subject did, the test results would be that their involved limb hop is approximately 95% of their uninvolved limb hop. Because the percentages are within 10% of each other, our patient is ready to return to sport. Literature indicates that at 16 weeks post-op, patients will typically be around 80%, while at 24 weeks they will be around 90%. There are expected norms for hop distance, but these are highly dependent on gender and age of the patient. Percentage measurements are usually preferred to assess the patient using the uninvolved leg as a control. This concludes our explanation and demonstration of the single leg hop test.